Good morning. So hemochromatosis is a very common condition in the Northern Hemisphere. It is a condition in which we have got a dysregulation in the trafficking or absorption of iron. As you can imagine, iron is a very important element which is used in various function in our body, primarily for making hemoglobin. We have got various forms of iron. One is the iron, serum iron, which is circulating in our body, and then we have got the deposition form of iron, which is called as ferritin. So in hemochromatosis, there is a dysregulation in the hepcidin, which is the main regulator of the trafficking of iron in our body. It is primarily caused by a genetic disorder, and as I said earlier, that this genetic disorder is primarily found in the northern hemisphere, in the Caucasians, amongst the Caucasian, and especially in the um, northern Europe, Irish, Dutch, Scottish, British white Americans, and also in Scandinavian population. So this gene is exclusively found, the gene defect rather, is exclusively found in the white Caucasian population. There are two genes which they are the main regulator of iron trafficking. They are called HFE gene or hemochromatosis gene. And you have mutation in these two genes which can cause the iron deposition in the form of ferritin. The signs and symptoms of hemochromatosis primarily happen because of the deposition of iron or excess iron in various important organs. So it is very important to understand what are these organs where the iron gets deposited in the form of ferritin, and that is called as iron overload. So the most important organ which metabolizes iron is your liver. So liver is the first organ which gets affected by excess iron. And then we have got heart, and then we have got joints, skin, our sexual organs, gonads, and also pancreas. So these organs get affected, or these are the organs where the iron deposition happen. And because of that, the signs and symptoms also relate to the organs where the excess iron gets deposited. So if you have got the liver derangement, or liver gets the maximum amount of iron, you can get liver derangement or liver function like AST, ALT, alkaline phosphatase, gamma GT. These enzymes will be raised. And gradually, when the deposition becomes quite excessive, then the liver loses its elasticity, or it becomes more fibrous, or later on it can turn into what you call a cirrhosis of liver. Which of course is not that common because the disease is picked up much earlier than that, and we can start treatment. So not all patients of hemochromatosis will actually have the full liver necrosis or cirrhosis and liver failure. However, you can have some affection of liver, and the fibrosis can happen in liver. So that's the sign and symptom from the liver side of thing. If you have got iron deposition in heart, which is also called as cardiomyopathy or hemochromatosis cardiomyopathy, the patients may feel shortness of breath on exertion, and primarily it can lead to heart failure if the iron deposition becomes quite excessive. If you have got the excess deposition in joints, they can have joint pains or arthritis, which can be picked up by the X-rays and MRI if you have got the hemochromatosis affecting joints. In very excess amount of iron, or a very chronic hemochromatosis which has not been picked up on time, you can have patients with the skin discoloration, or what you call ashen gray. the white screen of the Caucasians can actually come out as ashen gray or a slate-like color, which is the sign of iron deposition in the skin. Then, of course, if it gets up deposited in pancreas, you can have diabetes, early onset diabetes, and also then you can have the sexual dysfunction in the form of when the iron gets deposited in the gonads. The most important and the most common symptom of hemochromatosis actually is extreme tiredness and fatigue. A majority of the patient will have fatigue as their first sign or symptom of hemochromatosis. So, if anybody who is from the Caucasian origin and feeling very tired for unknown reason, for a worsening tiredness for a long time, then they should seek advice from the GP and get their ferritin and the transferrin saturation done to see whether they have got any evidence of hemochromatosis. Hemochromatosis can also be sensed or gauged by the family history. So, because it's a genetic disorder in the Caucasians, you will find they will be having some family history where the grandparents were affected by the condition, and they have had various forms of treatment. So the cause, as I said earlier, I alluded to that the cause is primarily genetic mutation in the 2-HFE gene. One is called C282Y, and the other one is called H63D gene. So the one gene, which is C282Y, is the main hemochromatosis gene, and H63D gene is the subsidiary gene, which is less problematic in terms of causing excessive iron overload. So you get mutation, which happens, somatic mutation and the germline mutation. So we can get and this mutation is primarily concentrated in the Caucasian population, as I said earlier. So that is the only cause of hemochromatosis as a disease, as we know hemochromatosis. Of course, there are other causes of iron overload, which are because of the chronic blood transfusion or liver failure and the hepatitis C and B in the South Asian and the Southeast Asian population, but that is not a hemochromatosis. When you say hemochromatosis, that means it is a condition of iron load because of the genetic mutation in these two genes. So the treatment is actually quite simple. It is not a drug treatment. When we talk about drugs, we start thinking about the side effects and complications of drugs. So the treatment treatment of hemochromatosis is primarily by what you call phlebotomy or venesection. What we do in that, we take it's like a blood donation. When we go for blood donation, a large bore needle is put into the into elbow or antecubital fossa, and one full bag of blood is drawn or taken out, as you do in the blood donation. That has to be done rather frequently in patients who have got very high ferritin load, where ferritin can be above 500 or even in thousands in the mutation of hemochromatosis gene. So here I like to also mention about that not all hemochromatosis or not all genetic mutation patients will develop hemochromatosis, because for the hemochromatosis to develop, or full-blown hemochromatosis to develop, you need to have homozygosity of the mutation. That means both chromosomes should have both copies of one gene mutated, and primarily the C282Y gene has to be mutated on both chromosomes to cause a full-blown hemochromatosis. If you have got only one chromosome affected, then that is called as carrier state, and the carrier state generally does not lead to a full-blown hemochromatosis. Same is the case with the subsidiary gene, the C282Y, the H63D gene, which is again much less important in causing the full-blown hemochromatosis. So the treatment is you have to go for phlebotomy or venesection into the hospital. to get your ferritin down between 50 and 100. That's the target we like to achieve as early as possible, so that the ferritin doesn't, the iron doesn't get deposited into various organs. And that can be achieved depending on what's the initial transferrin saturation is and what's the initial ferritin load is. We might have to do sometime 2 times a week, or every week, or every fortnight, or every monthly, depending on the starting ferritin level. So generally, patients do tolerate it quite well. The young patients, they don't feel too tired after the blood is taken out. And if they have any dizziness, they can have fluids at the same time as we do the venesection, so that they don't feel dizzy, or if the patients have any cardiovascular risk factors, or their own blood pressure tablets, etc., then we can give them fluid while we are taking the blood out. So the treatment is simple. When I'm saying simple, that means there is no drug involved to treat this condition. All we need to do is to draw blood out. After the patient has come into the maintenance phase of this, then what we tend to do is to continue venesecting the patient in the National Blood Service, where the blood can be used by the National Blood Service. So in the maintenance phase, we often refer the patient to National Blood Service for blood donation, regular blood donation, 2 to 3 times a year, and that should keep their ferritin and transferrin saturation in check. So the primary investigatory points would be that we need to check the transferrin saturation, how saturated the transferrin protein is. Transferrin protein is the transport protein of iron. We need to see whether it is above 50% saturated. And then if you have got high ferritin, above the level of the normal ferritin for the local lab, then we move on to the HFE gene mutation, which is a genetic test. And at the same time, we do check the liver function, the diabetes, the heart function, the liver ultrasound, the heart echocardiogram, and also check for the sex hormones. A hemochromatosis investigation can be instigated if the ferritin is high. So, and the ferritin can be high in various other conditions. First of all, we should understand that ferritin is an acute phase reactant. That means this level can go up in any acute condition. If you are unwell because of, say, chest infection or any other infection, the ferritin can go up slightly. But if it remains elevated and carries on to go up in its level consistently, and it actually becomes quite high, then of course we should start thinking about the hemochromatosis. Any chronic inflammation, arthritis, autoimmune disorders, rheumatoid arthritis, colitis, ulcerative colitis, and many other inflammatory conditions can cause the elevation of ferritin on a long-term basis. Then there is another cause behind the elevated ferritin, which is the liver disease. So if you have liver disease because of something else, not because of hemochromatosis, then also ferritin will go up in its level. Alcohol liver disease can be confused with hemochromatosis, where you have got cirrhosis, where we have got high ferritin. So, and if the patient is Caucasian, then we should rule out hemochromatosis. We must also realize that patients who have got hemochromatosis and they have got some liver affection because of hemochromatosis, they must avoid alcohol absolutely, because it is like putting fuel to fire. Then one important thing about some dietary changes for patients who are affected by hemochromatosis, that they should try not to have excessive amount of vitamin C or fruit juices around their meals, so that with their meals or immediately after their meals, they must not drink fruit juices like orange juice, where the vitamin C content is quite high, because vitamin C by its nature enhances the absorption of iron. On the contrary, they can take tea, coffee, and milk-based products with their meals or immediately after their meals, because the tannins and the phytates in tea, coffee, and milk-based products will inhibit the absorption of iron and let it be wasted in the stool. So these are the two very subtle changes they can do in their diet. Those patients who are affected and confirmed with hemochromatosis, apart from, of course, trying to avoid excessive amount of red meat, which contains a huge amount of iron. So these are the few things. Um, there is another very important point I like to point here, that I have in my own practice, I have found that there is a you often find high ferritin, not excessive amount, not going into thousands, but elevated above the normal range in the Southeast Asian population, and the cause is not clearly known. I think we'll have to do further genomics and further red cell gene and the HFE gene investigation as to why there is high ferritin in Southeast Asian population, especially the Chinese and the Southeast Asian population, Vietnam and Thailand, and around that area. So we should rule out the hepatitis B and C in these patients, which can cause raised ferritin if there is a liver disease or chronic liver disease. But quite often these patients do not have chronic liver disease because of hepatitis B or C, but their ferritin is still high and the cause is not clearly known. As we already know that hemochromatosis gene does not stay in the non-Caucasian population. So we do not have this mutation of hemochromatosis in these two genes in any other race apart from the Caucasian of the northern Europe. So these are the few points to be aware of.